ablation. We heard about that today. If we talk about spinal tumor surgery, for sure we have to divide between these two concepts. The one is the radical one, to get anything appropriate resections. The other one, the concept for metastasis, and in the session before we already discussed that you have to face different problems, major instability, neurological problems, or pain, and you have to that weigh out to the patient status that you have in front of you, the patient that lies in the bed in front of you. What kind of tumor do we have? What is the performance of the patient? Because after all, we have to say that if you take these numbers again in front of you, overall only 1/5 of the patient we treat with spinal metastasis will live 2 years following they were first diagnosed with a spinal column metastasis. So in general, we have patients with these metastases that have reduced general status, a lot of comorbidities, chemotherapy, radiotherapy, prior to surgical treatment. So the treatment goal has to be palliation in the majority of patients in a progressive disease. So we have to protect somehow function by giving them stability, and also by protecting the neurological function. So there are a lot of surgical options around now, and we all have to get in contact with these, from open stabilization, MIS stabilizations, maybe mini open surgery for decompression, separation surgery, as well as ablative techniques like SLITT, maybe you heard of that, or SBRT, EORT, radiofrequency ablation, coblation, and I will show you a bit of the publications about these techniques. So in general, I think we have to say in metastasis surgery that we have to be as minimal invasive as possible. If you compare the MIS surgeries to open surgeries, it's quite clear, and there's significant difference regarding blood loss, length of hospital stay. They have more or less the same neurological outcome if you do that minimal invasively. They have lower VAS levels, better health-related quality of life levels, and the major point from my side is that they have a shortened time to radiation therapy. So in some publications, they reduce it down to 2 to 7 days. And as I started, the patients were told that they have to wait 4 weeks or 5 weeks with huge open intralesional surgeries, and nowadays you can really send them the week afterwards to radiation therapy. And I think this is a big step. So we heard about this, the combination of less invasive surgery and SBRT, so-called separation surgery, and the good clinical outcomes. And the question from my side is always, is this concept maybe transferable to other techniques in indications like radio-resistant tumors or pre-irradiated areas? Maybe we can put on other techniques to not only do surgically reduce tumor, but also with other techniques. And there are some around. The first one of the ablative techniques is SLITT, that is majorly done, I think, in the MD Anderson in Texas, where they do a thermo therapy by a laser interstitial probe, where they online can monitor by an MRI how the tissue damage is going on during the procedure. They combine it afterwards with SBRT. So what they first do is, in first line, is reduce tumor in the spinal canal. They had quite encouraging results, but until now there's only limited access to publications or data. So this seems to be the right way, but I don't know if they are going on with that. We heard about radiofrequency ablation. There's another concept that's called coblation. The one is RFA is using local heating. Coblation is using evaporation, means in a water-like field. So both of them showed pain reduction in only for pain patients, doing this in monosegmental and combine it with kyphoplasty. They showed good pain reduction, VAS and ODI reduction, and there's one study showing also a reduction of tumor metabolism by doing this. So I guess this is the right way. The progress was also quite encouraging, but also here there are larger studies needed to do that. Maybe the most encouraging one is Kypho-ORT. This is intraoperative radiation therapy. This is a low-energy radiation that results in around about 80 gray at the tip of the probe. So you can directly, after planning it, as you can see in the level below, like SBRT, it's more or less the same planning. You can get 80 gray at the applicator surface directly into the metastasis. This is quite high dose. And this is combined also with kyphoplasty. So they have a quite good progression-free survival, 12 months following surgery, with an overall survival of about 12 months. So as long as the patients live, they will not see a local recurrence. However, this is quite problematic in terms of the infrastructure you need. You need a radiation therapist in your OR, and you need the facilities with a special OR theater and so on. So the indications from my point of view for these ablative techniques are the classic ones. As you know, it's standalone. Do this RFA or whatever, or coblation, and use it for pain therapy and combine it with augmentation. We also use it regularly as add-on in combination with the classical MIS procedures, percutaneous screws, and then just have something in front to give pain relief and then put cement afterwards. And then the third case, from my point of view, is to go on with the separation surgery concept, to say, okay, we have something where we can reduce tumor in pre-irradiated areas, in areas where the myelin toxic dose was also already reached, or in RCCs or melanomas where we don't have good radiation options. So just reduce tumor, maybe liberate the spinal cord, and then do SBRT in combination. So this is the classical case. Terrible story, 31-year-old female, breast cancer metastasis 4 years before diagnosed, with a quite bad hormone receptor status, oligometastatic bone, liver mets under denosumab, trastuzumab. So this was the CT scan when she was first seen in our service. She was only ambulatory in her apartment, had a VAS between 7 and 8. No neurological problems, but and a SIN score of 9, what is always shades of gray. So from 6 up till 12, it's always, I don't know what do you think about it, but it's always hard to decide. But she's young, she has 2 kids, so that's nothing for a solely kyphoplasty from my point of view. So what we did was just fast track percutaneous stabilization and did these radiofrequency ablation in this patient, did a kyphoplasty afterwards, and the outcome was, to be honest, 6 hours following surgery. She first went on the toilet, had a VAS for 3 days following surgery. I think she left 3 or 4 days following surgery home, and then went on to go to radiotherapy. So this is the easier cases. This is a 62-year-old male with a renal cell carcinoma on the left side that was diagnosed 2016. Resection of the primary tumor, had chemotherapy, is now oligometastatic in bone, has these has a T6-7 metastasis, as well as at the proximal femur on the left side. No neurological deficits, but pain. This is the tumor, mainly on the right side. So we decided to get him to a reduction of tumor around the spinal canal. Prior to surgery, for sure, we went for embolization, as we all regularly do for renal cell carcinoma. And then went for an open surgery in this case, did our screws, and then we just tried to reduce this tumor and get the tumor away from the dural sac. And then this is the post-operative controls, and we went then on for SBRT afterwards. More or less a similar case here, 57-year-old, also with the RCC, diagnosed 2010. It's under SUTENT, has metastasis, had a chest wall metastasis and pulmonary metastasis that was resected, and has now L4-5 metastasis with L5 syndrome on both sides, only pain, no deficiencies. So this was a tumor, quite bad localization for doing radiofrequency ablation alone, so we decided to do this in an open fashion in L5. So we also started with an embolization and then went on with open surgery, just did our screws, and did on the left side also this RFA and L5 and a decompression in L5 to get the tumor away from the dural sac, and then did SBRT afterwards. So as conclusions, for sure these are strong recommendations with a low evidence. Ablation can give a less invasive tumor reduction. Indications, the three indications that I already told you, is pain as a standalone device with kyphoplasty, or as an add-on on every other surgery you do, just to reduce tumor. You can spare abilities or even radiation load. For every indication where you have limitations of conventional radiotherapy, to reduce tumor in general and make SBRT possible. RFA seems easy to handle. You were maybe able to see that here. It's easy to handle. The duration and effect is not yet clear. We need more studies to evidence what's happening. It's still quite problematic. SLITT seems to be a good technique, but there's less information available, to be honest. Kypho-ORT could have the best effect. They are starting a prospective study now, comparing this to EBRT in a quite large study, prospectively. So I think they will come around with good data in maybe 2 years. But it still has the problem that you need to have these EORT facilities. So this is not a broad technique that every center can use, from my point of view. So we need more data to be more confident about the results. Yeah, and that's from my side. Thank you.
Thanks again, Alex. It's just us again. We should dim the lights and light some candles. I'm really interested in the radiofrequency, and I've just been speaking to Hani about it, and it seems to be promising. When you say there's very little literature, I mean, there is obviously. Who has the biggest series, and what are the sort of numbers that we're looking at?
Yeah, I think there is good evidence for bone metastasis and bone tumors for sure for the interventional radiologists. This technique is available for 15 years now. Correct me if I'm wrong, but 15 years around. So they use it more or less for now 15 years, and they have quite good results in tumors. But for the spine, I think the problem is to show in first the study what is really, and what I showed is, this is only, I think, is done for 10 patients, just to see what is the tissue doing. And then if you want to do that correctly, you need to do a PET scan.
Yeah.
Because the MRI has limitations regarding this. So we
Particularly
have
if you're
now
putting
intro
cement as well.
Yeah. But in some cases you can do that standalone. If you're doing maybe a stabilization, you don't need this. Maybe you can do that in an animal series or something.
Yeah.
But I think it's quite difficult to do to show if this is turning down the tumor metabolism and to which degree you really destroy cells, how big is the apoptosis rate you get by just heating it up, and we don't know that exactly. We are just...
So potentially you could biopsy it before you ablate it and biopsy it after ablation. And I mean, I think a cancer study will definitely pay for PET scans to be done post-operatively. And Steve Morgan, who was talking about his experience from Bristol, certainly showed a PET scan, several months later, and it had turned off, which is, I thought, very promising.
Yeah, but you have to do that in a series. And you have to watch it in different entities also, from my point of view. That's quite, because these group of patients is so heterogeneous. So if you tell something about breast cancer tumors, it doesn't automatically mean that renal cell cancer is...
One of the things I didn't want to mention as a criticism was that a lot of the talks had myeloma, and I just don't... The chemo is so good for myeloma that I don't think the radio ablation is necessary. And when you're talking about pain relief, I think actually the pain relief was probably coming from the cement augmentation, not the radio ablation. But I noticed in his series of 20, it was like half of them were myeloma. And I think you're going to have to extract those as an exclusion criteria.
Yeah, but I think we discussed that at the last NSpine also, that myeloma now, everybody says, okay, bring them to chemotherapy and not the way away from chemotherapy over the operations theater, because the first thing that helps them is chemotherapy.
Yeah.
And second line then radiotherapy, and then
that's right. You were
many other things
after Sean Malloy that year. I remember.
Yeah, many other things, and then at the end it's maybe surgery if they have a breakdown, or they have a fracture, or they have neurological problems. I totally agree that myeloma, I'm really defensive nowadays.
I agree. I think we have to be very careful about,
because we kill them if you create a complication and they will not receive their chemotherapy. You could just
I'd be quite worried about a necrotic tumor which could be infected in a neutropenic myeloma patient. I think that's actually potentially quite a dangerous situation.
Yeah.
Just wondering if you've had thoughts, because you've mentioned about spinal canal or debulking tumor within the spinal canal with ablation. I think you were alluding to that.
Yeah.
What's your thinking on that? I mean, are there particular tumors that you look at and you say, right, I'm going to try and... Are you trying to decompress the spinal canal with ablation at any point? Or what's...
Yeah, I try to, with any kind of technique, I try to get the tumor away from the dural sac. So if I have the impression intraoperatively that there might be a localization where I'm not that fine with my decompression, or it's just the posterior wall, and I don't want to grab too much into I just try to, after my decompression, I just try to get the probe in and just get the program through, and just know that from both sides, like the centralized one that I had in the end, just to get from anterior destruction of the tumor by this heating it up, and from the posterior side I come with my kerosene and try to get the tumor out there.
But not as the decompression, not as your primary decompression.
No.
Not done that.
No, that is what SLITT more or less tries to do. This is the thing from the MD Anderson where they just interventionally get the probe in and try to heaten it up by online MRI just to see that they don't destroy. But to be honest, I'm afraid of heating it up and just quite in the neighborhood of the dual sac. I try to get surgical, and there's something I have to do, to be honest. So I try to get the tumor away, and then maybe in this interface between the body and what I did for decompression, this is the area where I can do something to reduce just tumor, just to reduce it, and then go to SBRT, and they have to get rid of the rest. Yeah, it's easy for me because now we have the abilities to do that now, so we just use it, and we'll see where we go. Maybe another coffee now. Yeah, thanks everybody. There's no comments.